My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. And welcome to Operate with Zen. In this episode, we are talking about burnout and resilience with Yotam Heineberg. So Yotam, why don't you introduce yourself to the audience?
Yeah, hi, good to be with you, Phil. My name is Yotam Heineberg. I'm a clinical psychologist. I came out from Israel in 2005 to get my doctorate in psychology. And I think that my background of coming to Israel has context here too, because I was, without understanding why, very interested in the cycle of violence, trauma, and aggression. And in hindsight, it had a lot to do with my own origin story, where I came from, people in my family. And that was an intense focus for me starting out in graduate school. And as I was taking more and more steps towards my doctoral dissertation, delving into these dynamics, trying to understand why is it that hurt people would hurt people so often, it became evident that this is really a profound dimension, a core dimension, if you will, of the human experience. This is what our species does. We get hurt, and then in turn, we hurt others. And there was a desire that was developed and arose in me more and more in terms of wanting to interrupt that cycle and do something about it. And the more we looked at it, the more it seemed like compassion training would have an impact. So initially, I was interested in working with kids that were in inner cities or collaborating with folks that were working in war zones, had the honor of working with veterans that came back from war. And it was all these the same dynamic where people get hurt, they get traumatized, and in turn, they hurt others. So I went on to complete my postdoctoral training at CCARE, which is Center for Compassion, Altruism, Research and Education at Stanford University. And we got a deeper dive into what we call compassion training. So there are some Tibetan models that were developed with folks that are working with the Dalai Lama's team. And there is Professor Paul Gilbert out in the UK who developed compassion-focused therapy and compassion mind training. And these are things that I imagine we'll discuss more as we develop our conversation here. And after I completed my postdoc, I went on to become clinical faculty member at Palo Alto University, where I trained doctoral students in psychotherapy, primarily compassion-focused therapy. And being in a clinical training program, that also means that I'm essentially doing burnout work with these doctoral students and helping them kind of survive the perils and stressors of just being in intensive clinical programs. So working with doctoral students at Palo Alto University and folks who are going through the Stanford Medical School psychology training. Then in addition to that, I came back later to Stanford and spent a few years working as the burnout stress reduction guy at Dignity Health hospital chains. So we've done quite a bit of this work, primarily working with nurses, a little bit with physicians as well, supporting folks that are helping others. So the name of the program, the model they work with, we call it Helping the Helpers. And the intention is really to support folks that are engaged with clinical work, that are really trying to figure out how to help patients, but also stay grounded in themselves. And in addition to that, I run a private practice in San Francisco. And occasionally, I begrudgingly look at my half-written book and thinking the other half should be done. And I'm also working with a company called resilience.com, and our intention is to scale some of these practices using technology, digital tools, apps, and so forth, so we can reach more people to give them the benefits of these methods.
Thanks. And we're going to get a lot more into helping the helpers. And, that's what brought us together is actually Chris Bordoni, who was a guest on the first season of Operate with Zen kind of put us in connection. And so we've had some really good mutual conversations. So as we start talking about burnout and resilience, I want to get a little bit into, if you don't mind sharing, a little bit of your personal medical story, because you shared some of that with me before. And so just tell me about your early interactions with doctors and
Sure.
kind of how that shaped you potentially.
Sure, absolutely. I guess my early journey started out as a 9-month-old baby who couldn't go to the bathroom. And they had a hard time figuring out what was going on there. They thought it was an indigestion problem, but really it was a valve, a small obstruction around my bladder. And by the time they had figured out what happened, the bladder had leaned so badly against the kidneys and created a really intense system malfunction, I would say, in my entire kind of renal system there, which is tragic because I was born primarily healthy with the exception of that one obstruction. And it went on to multiple years of just being in and out of hospitals. I've had more than 12 surgeries, most of them when I was an infant and a child, a couple of them later on when I was a teenager. And I did have a really interesting experience that I now speak about with physicians when we meet, is I would engage a lot with nephrologists and urologists, such as yourself. And for me, as a little kid, urologists were a very scary bunch because these were the people that would cut me. And I had experienced a nephrologist, there's several of them. And in my, little toddler mind, they were kind, gentle creatures. And there was always a nervousness. And there was a nervousness about interaction as a little kid with surgeons, because at some point I'd realized what's going to unfold. We're going to meet with a person, they tell me they're a urologist, tell me there's a surgeon. And then weeks and months of suffering and discomfort would kind of follow. And there was a sense of, I don't know if I would call it toughness or harshness, it could be semantics, around being a little kid who's being operated on repeatedly.
Yeah, thank you for sharing. I bring that up. I just think it gives great perspective on kind of some of your interactions and some of your thought process around this, as well as I think it gives the audience a really good understanding of how we impact our patients and how we can be perceived and how that perception certainly influences the relationship.
And I want to add another way which you have impacted the patient. The patient is alive. So that's not a small thing. I would not be here chatting with you about my fear of surgeons had surgeons not operated on me. So that's a pretty important detail, I think.
No, and it's right. And you're absolutely right to bring that up. But I also think it's important as we try and be more mindful, thoughtful surgeons and providers, that it's not just the therapy we're offering and that it's a relationship, and that by cultivating relationships, we can be better doctors and better surgeons. And I think it's a really important story to come out of this.
Yeah, agreed. And when I was a little kid, I was adamant on becoming a medical doctor. I guess doctors were in some ways my heroes, even though there was some trepidation too. Over time, I decided I was getting my doctorate in psychology and really focused on relationships. But the emphasis on wanting to become a healer of some sort, I think that seed was planted in that hospital setting back then when I was a little kid.
That's beautiful. So I want to get into some burnout basics.
Sure.
And many people who are listening are probably familiar with burnout basics, but give us kind of your framework of burnout and specifically in the medical field.
Yeah, absolutely. I'm going to start at an informal way because it's been etched in my mind a long time ago. When I did my internship, the head of our training, Dr. Scott Fairhurst, beloved person, did a lot of work with traumatized children. He gave us trainings on burnout, and he would define it as a gradual erosion of the soul, which I thought was a colorful way to put it. And it's not disconnected from how I experience people dealing with burnout, and myself, I've had my own run-ins with burnout. And I pulled up actually one of our text cards on the app where I tried to summarize in the program how we think about burnout. So I'm just going to share a few words about it. It's rooted in our threat system, and it's supported by our angry or sad or anxious self. So it's really the idea that we have different parts to who we are. We have an anxious, angry, sad self. There's also a grounded, compassionate part that's rooted in our caretaking system. The problem with burnout is we literally get roped into this threat-oriented perspective, and we perceive reality through this lens of threat and risk. And it manifests through phenomena such as emotional exhaustion. Literally, we have post-traumatic stress symptoms, depression, anxiety. We feel stressed, checked out, or dissociated. Dissociation is very important. A lot of people literally have out-of-body experiences working in intense clinical settings. A lot of ruminations about memories of challenging experiences, things that might have happened in the hospital in a clinical setting, come back to us. I would say that the following is the biggest enemy in many ways: cynicism and dismissiveness. This way of just brushing things off, not really allowing ourselves to be emotionally moved by things, becoming blocked or blocking experiences from our emotional ability to respond, to react. There's a sense of distrust in self and others that comes along with that cynicism and dismissiveness. I think one of the most meaningful things that a burnout program can do is melt away cynicism and dismissiveness. That is the toxin that permeates all traumatic environments. So there's difficulty that comes with that in extending and receiving and expressing compassion for self and others. And naturally, there's going to be increased conflict at work and at home. And it comes with a profound dissatisfaction as well in our work life and in our home life. Now, this is not to say that any person dealing with burnout will experience all of these things. That would be a difficult life. Some do experience all of it, but some of us experience just part of it. There's also a flip side. We can become more satisfied by doing this kind of work, being invigorated, delighted by my own identity as a healer, as a helper, pleased with learning new things, and so forth. There are a lot of upsides, obviously, to doing this work. It's beautiful engagement with life, I think. And we need to be cautious to make sure we're keeping grounded, stable, and connected.
I think it's great. And the constellation you talk about, right? The cynicism, the dismissiveness, distrust, and dissatisfaction. I think all of us who work, honestly, probably in many fields, but particularly high-powered fields and particularly medicine, we all kind of fluctuate through these. And as I think back on my personal experiences, I think my first major burnout episode, I realized quickly this was not my first major burnout episode, right?
Yeah.
And that I'd been kind of cycling through these feelings. And I think one of the really important things for people to recognize are sometimes we can identify the trigger that's leading to burnout, but sometimes all of a sudden you find out I'm more cynical today. I'm being really dismissive to people I'm normally not dismissive to. And I've gotten to learn by the way I'm acting and trying to be more attentive to my own self when I'm going down that bad pathway.
Absolutely. And you know, in regards to cynicism, I have a dubious advantage over many people in the United States, is that I come from a country where there's a lot of friction. And I've been exposed to cynicism from an early age, also around my family members and so forth. And sarcasm and cynicism for me these are ways in which we cope with trauma. These are ways in which we cope with harshness. Something comes to mind that's really powerful to mention, even though it's different populations. When I was working with the veterans, and those folks, one of the groups I have in mind starting out were Vietnam vets, so much older. And they would say two things about dealing with life's adversity. One was, it don't mean nothing. And the second one, pardon my French, shit happens. And these were their two coping methods. Just brush it off, dismiss it, push it away. It don't mean nothing. And the problem is that it does mean something. And when the dreams come at night, or the stress comes during the day, or we notice ourselves being snappy and disrespectful towards others, colleagues, friends, family, patients, it does mean something. And I think the work is about gently approaching our suffering and caring for it in a productive way.
I think that's really interesting. And I've done some reading. I bet you, I'm going to hold a book up for you. I bet you've read this book.
Oh, of course. Yeah.
And fascinating read. It's The Body Keeps Score by Bessel van der Kolk. And the similarities between PTSD and burnout in some ways are dramatic. And you described before ruminations, and in the PTSD populations, it's the vivid dreams and kind of really strong reliving of the moments. And
I don't think it's quite fair to call it PTSD. I think that does a disservice to our service members who've truly experienced some tough situations. But it is certainly a PTSD-like syndrome, and I think it's poignant how you describe it.
I'm comfortable with calling it PTSD because there's plenty of research that indicates that nurses and physicians, especially those working in very intense clinical settings, develop post-traumatic stress. I think it's real. And, I will say this too, when I was invited to start doing work in the hospitals, I was perturbed by how well prepared I was to do this kind of work, because previously I was working with traumatized folks that came back from war or were in inner city settings or had dealt with sexual violence. So different forms of post-traumatic stress. So I am committed to honoring those who served and say, yes, they develop PTSD. And it's possible to develop PTSD because of a car accident or because of sexual assault, or because of working in a very intense clinical setting and repeatedly just being exposed to gruesome imagery and harsh realities. To me, this is the story of our species. Like when I say that my origin story for why I do this work has to do with the cycle of violence, trauma, and aggression, it happens everywhere. You could be watching harsh messages on TV and develop particular attitudes that are rooted in traumatic reactions. Now, that may not be full-on PTSD, but it's that interplay between the robust and nuanced, and we can find it in all walks of life.
That's fascinating. So I want to bring it out of burnout and now towards resilience. So in the model you've described, tell us now, how do we become more resilient? How do we work out of these burnout episodes, and how do we prevent them from happening?
Sure. Yeah, and with resilience is often described as the ability to bounce back, or the ability to come back to functioning or overcome adversity in a variety of ways. The particular model that we work with in compassion mind training, which again is really rooted in compassion-focused therapy, one of the things I really like about it is that it's not just trying to target things like stress, depression, anxiety, or even burnout symptoms. It's looking at to me, a more broad and meaningful human phenomena in terms of where we're going as a group, not just individuals. It's really about the ability to give and receive care, to give and receive compassion in three directions: the ability to extend it to others, to receive it from others, and to show it to ourselves. Now, what is compassion? When I speak of compassion, people oftentimes interpret it as a very kind of loosey-goosey or lovey-dovey concept reserved for hippies in San Francisco, perhaps. But really, when you look at what the concept is a sensitivity to the suffering in self and others with a deep committed to prevent and alleviate that suffering. So it's really about moving towards suffering. It's really about the ability to approach suffering with capability, with care, with wisdom, and with mindfulness. So for us, when we start doing this kind of work, we acknowledge that there's a lot of suffering in life. We acknowledge that we have a tricky brain that is oriented towards survival, that probably has a better safe than sorry mentality. And we have a very active threat system. When we face complicated realities, we're going to react in a way that is concerned for our own survival, maybe the survival of others. And that's how chronic stress is often developed for many of us. And we really begin by acknowledging these realities. One of the first things we talk about are what are the markers of burnout in this program, for instance. Then we start diving into why is it that we struggle so much as human beings, as a species? Like, why is it that a hospital setting would create so much stress for us? And it's really about this constant dwelling, if you will, around life and death circumstances. And it's odd. It's a silly thing to think that we're not going to have a reaction to these types of realities. So the first step, if you will, is moving towards suffering, acknowledging that it's there, and practicing what we call distress tolerance, the ability to be in contact with that suffering in a productive way, as opposed to avoiding or dismissing it. One of our biggest enemies is avoidance. You're muted, Phil.
Thanks. I really like the 3D model of extending, receiving, and yet being true to ourselves. And I think that's a really powerful take home for people. Doctors are really good at extending, right? Not so good at receiving and really taking care of ourselves. And that's kind of the way we're trained.
Yeah, and absolutely. And one of the challenges is what we call FBRs, fears, blocks, and resistances. We have a whole host of impediments around receiving, being afraid that we may not be able to trust others as much. If we extend too much, we might get used, we might get depleted. If I let people come too close, if I allow myself to receive, it's dangerous. I'm going to start trusting them. And then when I'm really going to need them, they're going to abandon me, like people in the past have. With regards to self-compassion, we are where we are at for a reason. These kind of professions where people are getting doctorate and trying to climb up these social ladders, if you will. It has to do with pushing yourself hard. It has to do with driving yourself really hard. I see it in my doctoral students often. They're very perfectionistic. And there's a tragedy there because treating yourself harshly to get things done is actually helpful in the short run. It has some benefits. Those 5 or 6 cups of coffee at 2 a.m. to finish up a paper or to finish up a project or take care of patients, whatever it is, you're going to make it through the night in some ways, but ultimately there's a residual kind of damage. So the idea, we talk about our emotional systems. I'll mention very briefly, we have a threat system that's very powerful. We have a drive system that helps us achieve and pursue goals. And then we have a soothing and caretaking system that's really the seed of compassion. It's rooted in our capacity to care for ourselves and others. And the challenge is that we get this pinball effect between threat and drive. So people are able to push themselves really hard and accomplish their goals in the short run, but really it's at the cost of feeling more and more stressed out, more and more burnt out, and our capacity for soothing and nurturance ourselves or other people begins to diminish. That's where cynicism creeps in, because if you don't have the capacity for nurturance, you're going to become more cynical. And the way you treat patients will suffer, the way you treat yourself, the way you treat loved ones. All these things begin to kind of fade away in some capacity. Just the ability for care and nurturance becomes more thin, if you will. So a big part of it is recognizing, how am I fueling myself with regards to my drive system? Am I caring for myself, nurturing myself, or am I just using my anxiety and sometimes even anger and drive to push forward? And then I get results that are filtered, if you will, through the emotional texture of things like anger, anxiety, impatience, a sense of depletion. That impacts outcomes, that impacts patient satisfaction, that I know is an important thing for hospital systems, and of course the well-beings of the individual.
Yeah, it's a great point. And, I think I've never really thought about it that way. I talk to my trainees a lot about, it's okay to push through a night. It's okay to kind of work really hard for a 24, 48-hour period, but you've got to give yourself a break. And I've just always thought about it more from a time standpoint. And I think back to the earlier training days where it was the initiation of the 80-hour work week, although that wasn't really followed. And medicine's gotten a lot more friendly in terms of time management. But I think this compassion component is really important and missing from a lot of the way we talk about these things. So thank you for bringing that to light. If you wouldn't mind, Yotam, give us first, just tell us, because a lot of the stuff you talked about now is on your kind of web platform and people can find these resources. So share with us kind of the web platform so that we can talk about that. And then I want to get into a little bit of nuts and bolts about compassion training.
Yeah, absolutely. Yeah, so the website is resilience.com, and just replace the CE with an S. And then if you go to the coaching platform, you can find the program for healthcare providers helping the helpers. And ultimately the intention with compassion training is formulating as well as forming a new relationship with suffering. Well, here's the deal. You and me, Phil, we both have a relationship with suffering, whether we like it or not. If I could get divorced from suffering and never experience, I might consider it, but that's not a realistic goal. So 100% of humans on this planet, I would suggest, have a relationship with suffering. So the intention is to begin to get curious about, what is my relationship with suffering? What about it has been serving me? What has not? So we start out by talking about, what are the components of burnout? What are the dimensions of mindfulness? How can I begin to mindfully orient to my experience? Then we go on to have some more psychoeducation around these emotional systems that I've described, this notion that we have a tricky brain that's more oriented towards survival, and how is that impacting my life? So there are opportunities to learn in terms of micro lessons, whether video or text lessons. There are also opportunities to engage in short meditations that you get a new one every week. There are opportunities for journaling. And I think the most important opportunities for team building and interaction between people on the team, people on the cohort, finding new ways, fresh ways to support each other throughout that. Because to me, what I have not mentioned enough yet that I want to say something about now is the importance of teamwork. None of this type of training in a clinical setting is going to work unless we emphasize teamwork, unless we develop understanding as well as empathy for friction on the team. Friction on the team is one of the biggest reasons why things don't work out. When I started working in the hospitals, they gave me an interesting task. They wanted to target the shift handoff, where people are beginning a shift or ending a shift. And so many of the glitches are about those interactions between different groups, the daytime nurses and the nighttime nurses. That was a big one. And any person who's worked in a hospital, I mentioned the mythical battle of daytime and nighttime people, there's always this chuckle. It's like, why is it? Like, we're not talking about, two species from different planets. We're just humans that work at night and work at day. But there's something about the social psychology of us and them that we teach. These are profound dynamics of in-group and out-group tension. So it's obvious if you look at a war zone or a gang reality, but it sounds kind of weird when you talk about, something like nurses working at day or working at night. But on a social psychology level of analysis, it's kind of similar. We have in-group, out-group tension, and each group thinks that they have their own characteristics. There's problems with the other group. The nighttime people, they don't do anything. They just hang out all day. We work hard. The nighttime, like, oh, we struggle, we toil. There's every group has their perspective. What happens really is friction. And we break it down and we smile at these dynamics of shared humanity, that our brains are wired for us and them. It has to do with our attachment system. Interestingly, that's maybe goes a little bit beyond the scope of what we're talking about here, but the ability to attach and have affinity and safeness with our father, mother, our tribe has to do with pushing away those who are different. So feeling safe has to do with pushing away he or her or they who might be different from us. So we talk about these dynamics in the context of understanding teamwork, understanding that you invite your angry self or your anxious part to go and have an interaction with a person who's supposedly on another team, even though we're all connected here as healers. And we try to bring up another part of us. We call it the compassionate self-identity. It's a part that is rooted in a sense of groundedness, stability, strength, authority, resilience, and has a lot of wisdom about some of the dynamics that I just mentioned. And notice this strong commitment for caretaking. And it's really a powerful modulating because it's trying to help the group reorganize around a comprehensive set of principles, saying, no, it's not us and them, it's we, the caretakers, we, the healers. And that also has to do with dynamics between physicians and nurses. Ultimately, we're all working on the same team, but our brains will break it up into in-group, out-group tension. So to me, it's a powerful set of insights to offer and to have people practice and engage with and have different discussions around. And we have, again, practices, journaling, meditation around it. But again, team dynamic, team interactions, things we can do throughout the week are going to have the most impact. And then we kind of culminate, if you will, by talking about, with more specificity, the three directions of compassion: extending, receiving, and self-compassion. And we begin to identify together the FBRs, the fears, blocks, and resistances, and hopefully begin to either reduce or melt away some of these FBRs towards creating a more capable team. And here's the really powerful thing to mention. Now I can circle back to that. When we're able to reduce fears, blocks, and resistances to giving and receiving compassion, we're also reducing stress, depression, anxiety, burnout symptoms. And that's what's really powerful about the model. There's a lot of research now that the correlations are very strong between fears, blocks, resistances to giving and receiving care and stress, depression, anxiety. So whenever we can build a more cohesive team where care is given, extended, and received, we have a more resilient team as well. And I think that's what's beautiful about the model. It's intuitively human, if you will.
Good. I want to share two insights that have come to me kind of while you're talking. And one of them has been, we get very protective in medicine. We get protective of our patients. We get protective of the way we think and the way we operate, for lack of a better term, as a surgeon. And we get offended when people think differently or act differently. And it's taken me a while, but I've really come to realize there are very few inherently bad people in this world. And they're just very few. They're just thinking differently. They're approaching it differently. And when you welcome in that additional perspective or try and see things from where they're coming from, it makes it a lot easier to kind of act in a conflict-free zone. So I've never thought about it once again the way you said it, but it makes a lot of sense to me. And I think it's a beautiful way of putting it. When I was going through kind of your program online and looking at it, one of the things that popped out to me was, well, what do you do if you don't trust your team? And I think you've kind of addressed a lot of that, but in your kind of clinical experience, have you seen really, I'm sure you've seen bad team dynamics, but kind of tell us, a little bit more about how to work with the team that's really falling apart. Is there ever a time you pull the plug? Or is this always a kind of reconcilable situation?
I think there have been times, what I've observed in general terms and on ER departments, I've seen plugs. I don't know if I'd call it pull the plug, but teams being reorganized because some folks just being quite upset with the way realities are. And I think that the important thing again is to recognize that we are wired to organize ourselves around in-group, out-group tension. I have seen teams that had a lot of friction on the inside of the team, and then you get the team to become more cohesive. And cohesive is an important word, by the way. I'll mention, in psychotherapy, the therapeutic alliance, that's the predictor of success. In group therapy, they call it cohesion. That's the predictor of success. What is cohesion? Cohesion is the desire, the wish to be part of the team. So I think it's a very important thing to create team cohesion. If people want to belong to the team, we have much better prospects of success. The pitfalls, if you will, is if you have a team that has internal friction and you get them to get along with each other, now they can rally up against, now we need to go against the leadership. So the us and them can get reorganized in another way. And the challenge, and I think the important task, is to figure out a way to create a collaborative mindset. One of the fundamental principles that I haven't mentioned yet, and again, this is Paul Gilbert's work on evolutionary psychology, is the fundamental tension of competition versus collaboration. I think overall, we do have these two major trajectories in which we, quote unquote, advance in the world. We can compete and have friction and grow from that. We can collaborate and then develop an alliance building and mentality, if you will. And importantly, both are valid, both have always existed, both will continue to exist. The challenge is that we get trapped in a competition mindset and all we can do is compete and get obsessed with who's above me, who's below me. And we get invested in making the other person or the other group look bad. So we talk about it as a fundamental principle of how our minds operate. There's no shame, there's nothing to judge, it's just how we function. And can we shift over from competition to collaboration? Because the competition mindset has more threat system activity, there's more stress, there's more friction, there's more suffering, there's more pain. With an alliance building mentality, a collaboration mentality, we have much better results. Now, these things are intuitively obvious. When I say them, I don't think anybody would disagree. And at the same time, how to get there is the question. What are the steps? What are the building blocks towards fostering a collaboration mindset, towards becoming more focused on alliance building and less afraid of who's above me and who's below me, which I think is just, again, fundamental to how we function.
So I'm the new leader of a team here at the University of Pennsylvania. And I think I've inherited a pretty cohesive team.
Right.
But if you had to give me, I don't know, 1 to 3 kind of concrete things as a new leader or as a team to promote cohesion, what are just real simple things I can do, from the outset?
The first thing that comes to mind is eliciting voices, and eliciting voices in a productive way. Some voices are good to elicit in a group setting. Other voices, perhaps people are displeased, might be more helpful to elicit in a smaller forum, if you will. When I was giving the task of working with hospital team members, and I was not giving a lot of time to do that, I offered very brief teachings, and then I used motivational interviewing to elicit people's voices about how to make the team more cohesive, how to make things work better. And I think that was a powerful exercise because there's not a whole lot of time ultimately in this kind of work setting. And there's the assumption that if you say the right thing, you're going to have a terrific impact. And there's something ironic because many times it's not about what you say, it's about the space you make for other people to express themselves so that they can feel heard, they can feel acknowledged. So my first suggestion is to elicit voices. My second suggestion is to, based on that, to support the organic emergence of connections between people. So there are some things that you can do in a structured way, but really when you have people, when you give people the opportunity to elicit voices amidst each other, they hear each other, and then you invite them to connect with each other, they're going to connect with each other in ways that you cannot predict. It might be a cup of coffee over break, or after, you know, they finish their shift, or another way of connecting, or just looking at each other, develop internal, I sometimes think about it as internal vocabulary. People develop some humor together and they have just a set of vocabulary that they get. So we create this internal team language, if you will. So eliciting voices and building connections to me seem like a really powerful method. And maybe the third, and this is a bigger one because it has to do with really taking a program of psychoeducation and so forth, is formulating and forming a new relationship with suffering. When I use these two words, formulating, realize has to do with understanding and configuring that there is a relationship with suffering. What does that look like for me? And then taking steps to form a more productive and helpful, and I think a compassionate relationship with suffering. So it starts with my own and then people on my team. And then I think it kind of spills over in a positive way towards relationships with patients.
That's great. So I want to move on because we're going to run out of time eventually. But, you know, some of the themes you've brought up throughout this, presence, being in the moment, being aware of not only ourselves, but what others are experiencing around us, and being non-judgmental are really core concepts of mindfulness.
Sure.
So tell me about your mindfulness experience. When did that start? What does your mindfulness practice look like now? And how does it influence it?
You know, I really recommend getting divorced because it's so painful. I had to do something. I mean, I was in this world for quite a few years before, and something about, you know, just my own little journey is when I got divorced, it hurt so much. I just needed to sit with my pain in a more intentional way. And I've been around meditation before, but it really had to do with moving towards that which ails us, moving towards discomfort in a way that, again, is caring and non-judgmental. It makes a lot of sense to talk about mindfulness. We have a module about mindfulness. And at the same time, for me, the way my experience is now with doing this work, mindfulness is really an integrated part of compassion training as a whole. So we think about mindfulness as being oriented to the present moment without judgment, with intention, focusing on the things that we want to focus on. And it's really to infuse it with this emotional texture of care and nurturance. That's where I think where we get much of the effect. So we have more distant forms of mindfulness where we're just kind of observing with curiosity. I think with the compassion model, we're really trying to shift towards our soothing system, our caretaking system, and develop the ability to observe the present moment, not only without judgment, but also with a sense of warmth and care and nurturance. And I think that there is the possibility of pushback that comes from people that are a bit cynical, which I acknowledge. If I was to say these things to my father, who is a war veteran, he would certainly respond with cynicism. So what I want to highlight is that we're just operating by acknowledging what we have, which we have different emotional systems. So we have a threat system that brings us stress, that brings us distress and suffering, and we have a caretaking system. So the intention is sorting out ways to take care of our own threat system so it doesn't take over us, and then shifting over to nurturance and caretaking and engaging with mindfulness from that perspective. And did I sit this morning for 20 minutes before we met? Yes. Do I consider that my core mindfulness practice? Kind of. Because really my whole day should be a mindfulness practice, and taking these small pauses for informal practice and really orienting when it gets challenging, through what emotional texture am I relating with this situation right now? And there are even micro practices that are quite helpful. For instance, on the days where I do risk consults, so once a week, I'm the risk consult guy for suicidal people at our university clinic. So someone knocking at the door, Dr. Heineberg, this person wants to kill themselves. And I'm supposed to know what to do about that, which I always find interesting, to say the least. And what I do is, and the more severe the incident is, the less likely I am to respond immediately. I will respond after 5 or 10 seconds. So I do two things. Then I hear the information, and the first thing I tell my mind to do is bring my attention to the bottom of my feet. So I just become intensely curious about the physical somatic texture of the bottom of my feet. And we can think about things like interoception, sensing the body from the inside. So I'm just wanting to notice the bottom of my feet and the contact that I have with the ground, and just feel that for a few seconds. And then the next move, I'll orient to my belly, and I'll see if I can breathe into my belly. Diaphragmatic breathing, if I can counteract, that kind of sympathetic nervous activation reaction, and just shift myself slightly into the parasympathetic space. It's not going to be a full-on practice, right? But just a little bit, where you become habitual. Bottom of my feet, belly, bottom of my feet, belly. When I go into my belly, I breathe. And really what the other person is seeing is 5, 6, 7, 8 seconds of what they would consider reflection. They might even err on the side of thinking that I'm wise. I'm just trying to regulate myself. And then I have a little bit more groundedness to respond to this difficult question. So I think, to me, this is a really simple and profound trick: bottom of feet, belly, and then come back to what's happening. And if you do it a lot, if it's habitual, you will have an effect. And you don't have to spend, lots of time meditating to get there.
I think that's great. I think that's really practical. And, your experience is clinically with patients who are struggling from either emotional or psychological issues. But I think that's also really apparent for surgeons too, right? We could be struggling in an operation or with a patient, and it's okay to sit there and take a pause and breathe and work through that. I think this concept of just kind of micro mindfulness is huge. And I think obviously building the practice and practicing with standard 5, 10, 20 minutes a day can help you develop those skills. But you're right, it doesn't have to be a major commitment to meditation to be able to use these skills.
It doesn't have to be. It does help, when we do formal practice for a while, then the microsecond skills are more readily available to us, of course. But it's really about acknowledging, moving away from mystical ideas and philosophical notions. I mean, you all are, physicians and working with the human body. You understand, sympathetic, parasympathetic nervous system, diaphragmatic breathing, interoception, proprioception. These are all concepts that are readily available. And how can we work with them in a practical, simple, applied way?
No, and I just want to bring it to the audience's attention that there's really good data to support everything we're talking about today. Loving kindness meditation, which is similar to compassion training. There's data that basically, just 7 minutes of a loving kindness practice can improve feelings and social connections. It's not going to be lasting. And as you work on your practice, you can make changes to your brain that will literally lead to a more compassion-filled life and a better interaction with people. So really great points, Yotam.
Yeah, I agree.
At this point, as we're wrapping up, I want to give you the opportunity to talk about, helping the helpers, or anything else you want to talk about at this point that you think would be important for our audience to know and hear about.
Yeah, I appreciate it. Yeah, so, helping the helpers is ultimately a culmination of having done this for quite a bit in person as well as online. And the intention with helping the helpers, again, we're running it through resilience.com, is really the idea that we want to offer hospital workers, whether it's physicians, nurses, nursing assistants, or different people working in clinical capacity, the opportunity to benefit from these lessons in a way that would scale. So I think one of the challenges is that even though the messages could be good, they haven't been up till now readily available on your phone with things like push notifications. You can do the meditations on your phone. You can interact with your team members through a community space, or watch micro lesson videos, or these brief kind of text exercises, if you will. And just do it in a way that fits with what technology can offer. There's been a little bit of a disconnect between mental health services and what technology can offer. And the intention here is to really bridge the gap and find ways to support folks that are working as clinicians, that are helping others to receive help themselves so they can live happier, more resilient lives and reduce burnout, of course.
And I'll make sure we put these resources on the website so people can access them, but it's Resilience with an S, not a C at the end.
Not a CE, exactly.
Yes, at the end, and helping the helpers. And we will make those available to the audience here. So on that note, I'm just going to kind of summarize some of the really important things we talked about today. You gave us your personal story. You told us where you come from and why you are who you are today and why you're helping people.
And what feels important to me with the personal story is also to express gratitude for the fact that I'm here. Yeah. Much good to be acknowledged about your profession.
Well, thank you. And we express, gratitude to you as well. We talked about the basics of burnout and resilience. I thought it was really strong how we talked about compassion training today. The 3 dimensions of extending, receiving, and self-compassion, I think, are really important for people to think about. Kind of the core concepts of mindfulness, presence, awareness, non-judgmental in a team atmosphere, where we understand how the team works together and building those relationships with our teammates, whether we like them or not at this moment, really are going to be our core principles to being resilient, to avoiding and overcoming episodes of burnout. And that these kind of micro mindful episodes throughout the day can really enhance an experience, give us perspective, and keep us moving in the right direction.
Absolutely.
Well, good. Well, Yotam, I can't thank you enough for speaking with me. And I think a lot of people are going to benefit from this conversation. And hopefully we can do another one in the near future and get into some more specifics about compassion training.
Yeah, it's a joy to be with you. Thank you so much.
Well, thank you for being here. And thank you to everyone for listening to this episode of Operate with Zen. Take care.